Obama tweeted a statement and his reaction, saying, "Today a jury did the right thing, but true justice requires much more." It's a case that sparked protests and dominated headlines across America and the world last year. British newspapers have already published the verdict on their front pages for tomorrow. The European body, which decides on the suitability of medicines used in the EU, says there's a possible link between the Johnson & Johnson COVID vaccine and very rare blood clots. It says the vaccine should carry a warning, but the EMA concluded that the benefits of the jab outweigh the risks. It says the blood clots were very similar to those that occurred with the COVID-19 vaccine developed by AstraZeneca. 7 million doses have already been administered in the US, none yet in Europe. The BBC's Anna Holligan reports.
The EMA's Safety Committee has been assessing the data from the US rollout and found there might be a link between this extremely rare blood clotting and the Johnson & Johnson vaccine. All cases were found in people under the age of 60 within 3 weeks of them receiving the vaccine, and the majority of them were women. But the EMA has said it's too soon to say whether there are specific risk factors, so for example, age or gender. The European Regulator's Director, Emer Cook, has said it's important to recognise these possible side effects because early intervention can make a difference. And she also said the benefits of the Johnson & Johnson vaccine outweigh the risk of possible side effects. This vaccine is different from the others that have already been approved for use in the EU in that it requires only a single dose, plus it can be stored at a normal fridge temperature, which makes it easier to distribute. There are a lot of hopes riding on this one. It's up to the individual governments to decide how they interpret the EMA's guidance in deciding who should receive which vaccine and when. And actually, Johnson & Johnson paused its European rollout after these possible issues were detected in the US out of what it described as an abundance of caution. Now, Johnson & Johnson and AstraZeneca work in similar ways, so it's perhaps not surprising that the EMA has detected these possible similar side effects, and it's continuing to monitor the situation as more and more data comes in.
Anna Holligan reporting from The Hague. India's Prime Minister Narendra Modi has ruled out imposing a national lockdown, despite admitting a new wave of COVID-19 has hit the country like a storm. Addressing the nation, Mr Modi says federal states should avoid lockdowns because they harm the economy, and people should show self-discipline instead. Vaccine makers in India have been urged to step up production. In the capital, Delhi, 99% of intensive care beds are full, and hospitals say they are hours from running out of oxygen. Tens of thousands of unaccompanied children are currently being held in US government custody, and the number continues to grow. President Biden promised change at the border, but he has extended rather than repealed one of the most restrictive immigration policies ever implemented at the US southern border. President Trump's Title 42, brought in to prevent the spread of COVID-19, effectively closed the border to immigrants and halted the asylum system. The Biden administration has kept it in place, but is allowing unaccompanied children to enter the country, which, as Sophie Long reports from Tijuana, is leading desperate parents to take ever more desperate measures.
Under a bridge which tens of thousands of vehicles cross every day, hundreds of families camp crushed up against the border wall. Women wash clothes while their children cry, exhausted by this noisy, unsanitary existence. When night comes, it's their mothers' tears that fall, while their fathers, if they still have them, lie awake with their fears. They came here in search of the American dream, but this is their reality. And it has been as days became weeks, weeks became months, and for some, months slowly turned into years.
My husband got killed. The violence and everything got worse. And, well, they told us that they were going to come for us.
In her tent with her baby strapped to her chest, and her young son and daughter playing by her side, Rosaura tells me her husband was killed by the cartels.
We need good life for our kids. That's why I came over here.
And yet she says their stomachs are sick almost all the time, and she lies awake, alone, and terrified about what might happen to her children.
They take girls and do bad stuff. They get abused, they get killed, they get taken. I don't sleep at night.
Rosaura is literally a stone's throw from San Diego and the safety of the United States. She can see it. She looks through the metal gates at what could be every day. But she's stuck in one of the most violent cities in the world with just a thin sheet of nylon for protection. So we're just at El Chaparral camp, and there are loads of kids out playing in the bright sunshine on scooters and with balls, but there are tents and makeshift covers that go all the way up to the gates where people leave Mexico and enter the United States. We've spoken to many people here, and they say they're hopeful that the rumours they're hearing that President Biden will open the border are true.
The BBC's Sophie Long reporting. Dozens of celebrities, including actor Leonardo DiCaprio and singer Katy Perry, have sent a letter to President Joe Biden urging him not to agree to any environment deals with Brazil's President Jair Bolsonaro. The United States has been holding talks with Brazil since February to stop the increasing destruction of the Amazon rainforest. Deforestation has skyrocketed under the right-wing leader, President Bolsonaro. And that's World Watch for today. Kia koe, Miriana.
Kia ora Pelina, koina te pūrongo o te pautūtanga mō tēnei rā. Rua te kaumātahi o Painga Whawha. That's Midday Report for Wednesday, April the 21st. We'll be back our pōpō tomorrow with interviews and the latest news from Aotearoa and the world. But for now, from the pautūtanga team, ki pai tō rā.
RNZ News at 1. Good afternoon. I'm Marama Tipole. The National Party has decried the government's shake-up of the health system as reckless, saying small communities will be stripped of their voice. Its health spokesperson, Shane Reti, says the proposed regime will likely end up another sprawling bureaucracy. ACT is more supportive of the plan to merge all DHBs, but says it is undermined by the proposed separate Māori Health Authority. Health spokesperson Brooke Van Velden says all races should be catered for by one system.
We shouldn't be separating people into Māori population versus everyone else. You know, we also have Chinese people, Indian people, Pacifica people. There are over 200 different ethnicities in New Zealand.
Brooke Van Velden says she would also like to see more focus on pharmaceutical funding. The new Māori Health Authority will have its own budget and the power to choose what services it funds. Sitting alongside Health NZ, it will also have joint decision-making rights on strategy and policy at all levels. However, the Ministry of Health will continue to monitor Māori health outcomes. Iwi Māori partnership boards will help determine the needs of Māori at a local level. The changes go further than last year's Simpson review of the health and disability system, which could not reach consensus on whether the new authority should have commissioning rights. The former Minneapolis police officer Derek Chauvin has been convicted of second-degree murder after kneeling for 9 minutes on the neck of George Floyd last May. The BBC's Nick Bryant was listening as the verdict came in.
Guilty of second-degree murder, that's unintentional murder. Guilty of third-degree murder. Guilty of the manslaughter charge as well. And the question, how will this verdict be received around the country? For a lot of African Americans, there will be a sense that justice has been done in this case, but obviously they're looking for justice across the board in so many other areas of their life. So this has been such a moment of racial reckoning. But the question remains whether this will be a moment of racial reconciliation.
Nick Bryant in Minneapolis. The COVID-19 response minister, Chris Hipkins, has praised the border worker who contracted the UK variant of the virus while cleaning planes. Health authorities are investigating exactly how the worker became infected. Mr Hipkins says the worker did everything right to keep themselves and others safe.
The worker concerned was a very diligent worker, signed in regularly, was tested like clockwork every week. He had both their vaccinations early in the program, regularly scanned QR codes, wore PPE as appropriate.
Chris Hipkins says it is possible the worker was infected through droplets.
Kia ora everybody, good afternoon. We'll start today with a bit of an update on vaccines. Shortly you'll hear from Dr Caroline McElnay on our current case numbers, including yesterday's border case. But ahead of that, I just want to confirm a few key pieces of information. The whole genome sequencing that we received last night, confirms that there is likely, or it's a highly likely link to a case who arrived on the 10th of April. We've since been able to confirm that the cleaner concerned did clean the plane that person arrived on. All of the tests for household and close contacts so far to date have been negative. And Dr McElnay will have more information on that shortly. Moving on to vaccinations, I'm very happy to report that this morning at the Ropata Clinic out in Lower Hutt, I received my second COVID-19 vaccination. I know you all want to know, I'm feeling fine. Once again, it was a trouble-free experience, very professionally delivered by members of the highly trained teams that we are so fortunate to have rolling out our vaccination. I'm happy to report also that we're very much on track. As of last night, 183,351 doses of the Pfizer vaccine have been administered to date. A total of 140,580 people have received their first dose of the vaccine, and a total of 42,771 have received the second dose and are now fully vaccinated. 41% of our first dose vaccinations have been delivered in the Auckland region. That equates to around 58,000, or just over 58,000 people, 19% of whom are Māori or Pacifica. Other DHBs across the country are also increasing their rates of vaccinations. Vaccinations so far have been administered across 142 different sites, utilising around 1,200 active vaccinators so far. 2,500 people, more than 2,500 people, have now completed the vaccinator training that's required for them to administer vaccines. Over the last 7 days, we've had around 100 vaccination clinics operating. That number will fluctuate a little in coming days, particularly as we see a number of larger scale clinics opening up. Some of the smaller scale ones may close. Across the country, 12,697 Māori have received their first vaccination. Of those, 4,343 have also received their second dose. We've given the first dose to 16,314 and fully vaccinated 7,478 individuals of the estimated 50-odd thousand household contacts of our border workers that we are aiming to reach. I'd like those numbers to be higher. And so my message to all of the household contacts of our border workers is please do come forward and get those vaccinations. You are able to get them now. Please work with the local health teams, with the household contacts employer if necessary. Come forward and get those vaccines. You are able to get them. Group 2 vaccines are proceeding ahead well. 104,596 first doses have been given to that group, with 21,791 of them now being fully vaccinated. Our stocks of Pfizer vaccine continue to build. The shipment of 78,390 vaccines arrived earlier this week. That brings our total number of vaccines to date that we've received to 685,620. That's enough to vaccinate almost 350,000 people. So it sits at about 342,000 people we can vaccinate with those ones. I know there's been keen interest in border worker testing, so a few quick comments on that. I have I am writing to the chief executives of all of those agencies and private sector organisations that are working at the border to remind them of their obligations under the border worker testing regime. They need to make sure that their workers are being tested and they need to make sure that they are keeping records of that, and I'll be reminding them of that. It is an essential employer responsibility. It's underpinned by the border worker testing register, but as I've indicated before, only employers are in the position to ensure that 100% of those who need to be tested are being tested. This was also an opportunity to remind the wider agency teams about the benefits of vaccination, ensure that they are encouraging people to get vaccinations when they are offered one, and of course talk about the benefits to vaccination in terms of our ongoing recovery from COVID-19. Over the weekend, we began to ramp up our public information campaign around vaccines, designed to ensure that New Zealanders get good, reliable, impartial and fact-based information about vaccines. So you may have seen that the content appearing in our print media and across social media and on radio continues to increase. We've had information out there for some time. We're pushing it out a bit more now, and that'll start to ramp up again over the coming weeks. The campaign's basically got two main layers to it. One is just the fact-based information, and the second is encouraging people to be vaccinated. So talking about the fact that the stronger our immunity, the greater our possibilities. And so you'll see that in the campaign. Finally, before I hand over to Dr. McElnay, I am usually reluctant in this forum to talk about conspiracy theories, but I do want to address one of those today. I am aware that there are people handing out material, printed material, that looks professional, that undermines mask wearing on public transport. They've been particularly active in the Wellington region. They've been handing out mask exemption cards that are based on the official exemption cards that are available to those who need them. And they are handing out a pamphlet which, whilst it looks professional, has a lot of information in it that is factually wrong and potentially dangerous. So my message to all those coming through the Wellington train station is if you receive one of these pamphlets, the Wellington train station has helpfully provided a variety of receptacles for them. They're called the rubbish bins, and I would encourage you to put them there because that's about the only fit place for them. This group's actions are highly disrespectful to the small number of people who genuinely do need an exemption from the requirement to wear a mask because of a health or disability related reason. So I want to thank all of the Kiwis who continue to do the right thing on public transport in wearing a mask and those who are using an exemption card responsibly. Mask wearing is simple, it's effective, and it helps to keep us all safe. So I'll now hand over to Dr. McElnay and then we'll open up for questions.
Thank you, Minister, and kia ora koutou katoa. Today, there are no new cases of COVID-19 to report in the community, and one case detected in a recent returnee in our managed isolation facilities. That person arrived on the 16th of April from Switzerland via Qatar and tested positive at day 3 routine testing. It is very encouraging that we have no additional cases linked to the border worker we announced yesterday. And just to note, this person has been added to our official numbers today. This person was last night moved to the Auckland quarantine facility, and they have been immensely helpful as we work to trace their movements over their infectious period, and we're very grateful for their cooperation. We have now identified that the person has 25 close contacts. As the Minister said, the 7 who have been tested so far have all returned a negative result. 1 is being followed up today, and the remainder of those identified are not yet due for testing. This is because we test close contacts on day 5 after they have potentially been exposed to the virus for the best chance of detecting any infection that may be incubating. They are, however, in isolation. Of those 25 close contacts, 17 are workplace contacts. The person worked 3 shifts during their infectious period with a number of colleagues, and officials are working through those lists to determine who is a close contact from their interactions. As we said yesterday, the person who has become infected works at cleaning planes from international flights. This includes countries that are deemed red zone, where COVID-19 is widespread, but also includes having cleaned green zone planes flying back to Australia, on Monday. This is the same protocol that is used in Australia. The person wore full PPE while cleaning, and we have been in touch with Australian authorities to notify them about this case. Our assessment is that there is no additional risk to any passengers who travelled on those flights cleaned by the infected person. As the Minister said last night, we received the results from whole genome sequencing for this person's PCR test. The whole genome sequence was indistinguishable from that of a person who arrived in the country on the 10th of April from Ethiopia via the United Arab Emirates. The genome of both these cases is the B117, which is otherwise known as the UK variant. We have confirmed the person we announced as a case yesterday did clean that plane. While there is a clear link to a known case of COVID-19, we are still investigating how the cleaner was infected. And for locations of interest, there are no new locations of interest, but this case is an important reminder to keep using the NZ COVID app, Tracer app, to keep a record of where you've been. If you have been at the same place as a person who later tests positive for COVID-19, we will be able to quickly get hold of you to let you know what you need to do. And the ability to do that can help save critical time in stopping the spread of COVID in our communities. It's also a reminder for us to keep up our public health measures, and they are: wash your hands, wear a mask on public transport, use the COVID Tracer app to scan QR codes and turn Bluetooth on. Stay at home if you are unwell, and contact Healthline about getting a test. And when you are offered the vaccine, please take it and protect yourself and your whānau. It's particularly important we have people coming forward to be tested for COVID-19 so that our surveillance testing can pick up any cases of the virus that may be in the community. And just to note that our laboratories yesterday processed 4,771 tests. Thank you. Back to you, Minister.
Jessica.
So we've heard for weeks now about having separate systems at the border, separating red and green zones, and yet you're telling us today that a cleaner was able to clean both planes. Is that acceptable?
So there's a difference, I guess, between the way we handle passengers and the way we deal with people who may work at the airport. Bearing in mind that if a passenger is arriving through the red zone, they will then be isolated for 14 days. A person who is working in the red zone, we have very robust infection prevention and control measures to keep them safe, to prevent them from being infected in the first place. They leave work at the end of the day, they go home to their families, they are free to move about within the community, they go to, it's difficult to say to someone that you can go out of work and you can go to a concert or you can go to the movies or to a public event, but you couldn't go and work in the green zone. There are measures, though, and these are common between New Zealand and Australia, so we follow the same protocols. When someone's moving between zones, typically in a work shift, we would say that you can move from the green zone to the red zone, but not from the red zone to the green zone in a single shift. But when you are shifting, PPE requirements change and so on, so people will be changing their PPE.
Doesn't it seem pretty simple, though, to have a set of cleaners who do red zone and a set to do green zone? And how difficult was that conversation to Australia saying that the cleaner was cleaning both red and green zone flights?
So, as I said, the Australian protocols are the same. So the same thing happens in Australia as well. Ultimately, the risk of someone who is cleaning a plane passing on an infection is minimal, if there is any at all. The chances of them picking up the virus, of course, is relatively minimal as well. The investigation will tell us more about whether there is something additional that needs to happen here. The person was wearing PPE when they were doing those jobs.
Will you look at changing the system?
Look, we'll look at changing the system if the investigation highlights that there's a need to change the system. At this point, I haven't seen anything to suggest that it does need to be changed.
How can you Say that you've got robust procedures in place to prevent infection happening when this is what has happened.
Look, like I said, the investigation process will tell us more about whether there is anything additional here that we don't currently know about. So is it possible that the person came into contact with somebody off that plane, one of the crew, for example, on the plane, bearing in mind that some of those crew won't have stayed in New Zealand, we won't have tested them in New Zealand because they may have turned around and left again straight away. So that's what the investigation process gets to the bottom of, so we look at all of that. So it's possible, for example, that the passenger on the plane that tested positive through MIQ, that potentially they could have been infected on the plane by the same person that infected the cleaner. So all of those sorts of things are the things that the investigation process would identify.
But wouldn't that, there's surely some massive failure that's happened there if someone from the flight has been able to infect someone working on the ground cleaning the plane?
Obviously, we don't yet know how that has happened. So I don't want to say that there has been a failure. There could have been a mistake somewhere in the process, which would be, unfortunate. But at this point, we don't know. So at this point, we know what the risks are. We do understand those risks. Clearly, at this point, while we know how, where the infection's likely to have come from, we don't yet know how. And so we have to look quite closely at that.
Minister, why is the vaccination rollout seemingly 10,000 people behind the target that was set last week?
So there are a few data issues that we're working through. So one of those is that's a Wednesday to, I think the table that was put out last week was a Wednesday to Wednesday table, and the data that we're talking about today is a calendar week table that ends on a Friday. So what I've asked the team to do is make sure that the data sets align so that we're reporting consistently against the plan that was released last week.
Saying that you're likely hitting that target now, or because if you're 10,000 behind, you're probably.
Well, I can tell you that they did 9,000 on Friday. So again, I think there's a calendar alignment issue that they're working on in terms of reporting the data, just to make sure that that the time scale is consistent across the data that's being reported and the targets, if you like, that have been set out.
Just to be clear, the data that you released today is to Tuesday night?
No, I believe that data is till through to Friday. So that's right, and so they're just making sure that they're aligning the data, so that so from next week we'll report consistently. But I understand that it's just not consistent today.
You're confident that you're not more than 10% behind?
No, the advice that I've had so far is that we're actually just slightly over, although there are unders and overs within that. So some DHBs are a little bit under, some DHBs are over.
We're aware that there's a company that work on the border who do air conditioning who haven't been able to book in for vaccinations, and they have raised it with the ministry, so I'm not sure who would be best to respond to this, but why are these companies slipping through the gaps?
Look, very difficult to comment on that without knowing the details of that particular company, but if they've got people who are working at the border, then they are eligible and they should be able to access a vaccine. So certainly get in touch with the relevant district health board in the first instance to make sure that, that the appointments are being made available to those people.
Will you also be looking at changing the rules, just following up from Amelia's question about the protocols that were in place on the airline? Obviously there are rules in place for them at the moment, but is that another thing that you would look to enforce more closely or keep an eye on?
Oh, look, we always look at, whenever there's a case, and this case is, again, every case that we've seen is different to one that we've seen previously. There's no other cases we've seen in New Zealand that in any way sort of look and feel like this one does. So we always look when we get a case like this that's unexpected, that's difficult to identify immediately what's happened. We always look through the investigation process to say, is there something more we can do in the system to really minimise the risk of it happening again? So we'll absolutely do that here. But I'll ask Dr McElnay to comment on that too.
No, I was just going to support those comments. We are actively still investigating, so more information will become available, and we will clearly share that information with you when that does become available, and advise ministers of the need to change any of the protocols if that is what the evidence suggests.
Do you know how quickly the cleaner boarded the plane after the passengers or the flight had disembarked?
No, I don't have that specific information to hand.
So on Radio New Zealand this morning, you were asked what the trigger point for the Trans-Tasman bubble pausing might be, and you said
we need to be looking at unidentified community transmission cases. Is that the same trigger point for Australian authorities?
So the conversations that I have had with Australia indicate that they are approaching this broadly the same as New Zealand is. Now, you'll recall this was quite a point of discussion through the first part of the year, where we were initially aiming to have a common framework that we both agreed that guided our decisions. We weren't able to agree that, but if you look at our framework, it's very much aligned with our alert level system. So if something, if we're going to see an escalation in alert levels, you'd expect to see something happening around the Trans-Tasman. We keep in regular contact. So as soon as I found out about yesterday's case, I sent a message across to my Australian counterpart. He sent me a message back. We do keep in contact where we need to. So I expect that now that we've got much greater movement of people across, across the Tasman, things will be a little more predictable. We will be keeping in regular contact. So I don't intend to surprise Australia at any point, and I don't expect that they'll be aiming to surprise us. So I think that we'll be in regular contact.
Can you give us a bit of insight into how that relationship works? Because it's not just the Australian health ministers, it's state and territory health ministers and their authorities as well.
That's right.
Are you pleased about how it's gone over the last 24 hours?
Oh, absolutely, I am. I think the Trans-Tasman, the bubble was operating very effectively. I'll get Dr. McElnay to comment on what happens at an officials level. Depending on what we're dealing with, that dictates to some extent what happens at a political level. So I will keep in regular contact with Greg Hunt, the Minister of Health in Australia. If there is a particular reason to keep in touch with individual Australian states, then I potentially would keep in touch with a counterpart there. If there's a need for the Prime Ministers to keep in touch, then obviously, or the state premiers to be involved, then the Prime Minister would tend to lead those conversations. But at an official level, there are a number of layers to that, and I'll ask Dr. McElnay to comment on those.
Thank you. So we have an agreement with Australia that if there's any case that we need to know about, that they will notify us officially through the National Focal Point, which is an internationally agreed method for countries communicating with each other, particularly on public health issues. So we've got that agreement. Plus we've also agreed that there will be a phone call either into myself or to my office, so that we've got a heads up that something is happening, and then that is followed up the next day with a meeting. That doesn't happen every day, but when there's an incident in Australia or here, there's a daily meeting of the Australian Health Protection Principal Committee that I'm a member of, and that is made up of myself plus the chief health officers from each of the states, plus the chief medical officer from the Commonwealth. And it's at that point we discuss as a group of clinicians the individual case and do a risk assessment for all parties that are there at that meeting.
Just one more if I would mind. So Greg Hunt yesterday was very complimentary of New Zealand's ability to handle this outbreak, and I'm guessing just generally. Australia's view has certainly come a long way, potentially, from where it was last year. Does that please you?
Yeah, look, and I have a lot of confidence in the Australian systems as well. And in fact, what we've seen on both sides of the Tasman in recent times is that alert level escalation's only been used when it absolutely has to be. By and large, we do place a real emphasis on our contact tracing systems containing and eliminating any COVID-19 cases that do somehow make it out.
There has been a story breaking in Australia in the last couple of hours about a man in Brisbane who had a blood clot 3 days after having the Pfizer vaccine. This is something that was warned about. Should we be, heightened to that here, since that's obviously playing out the way that was warned, even though it is rare?
So the feedback I've had so far is that blood clotting is not a commonly associated side effect with the Pfizer or mRNA vaccines. It has been more, and it's still very, very rare, but it has been more associated with AstraZeneca and the Janssen vaccines, for example, which we're not currently using in New Zealand. It's important to remember that cause and effect here can sometimes be difficult to establish. People do get blood clots unrelated to vaccines. So without knowing the details of that and without having seen any of the medical evidence on that, it's difficult to draw conclusions. But yes. Dr. McElnay may know more.
Thank you. And yes, we are actively monitoring what is happening with Pfizer vaccine across the world. We have our own independent safety monitoring board that's been specifically set up to review any adverse events that happen within New Zealand, but also to be aware and to keep in touch with their counterparts overseas so that we can be alert to those sorts of incidents.
On writing to border worker employers, is what prompted that? Have you been made aware that some aren't meeting their obligations?
Well, we know as of last week that we had at least one, and I want to make sure that it is only the one, and that all of the employers absolutely know what's expected. So it's for the avoidance of doubt more than anything else. We'll come over here. Yes.
What specifically needs to be done to change the regulations to allow those unregulated vaccinators to work? And is there a date for when they can start working?
I'll ask Dr. McElnay to comment on that one.
There is a very active process underway to determine what is the training requirements for unregulated workers to be able to safely administer COVID vaccine, and that's work that's underway. Once we've determined the safety parameters, so that we've got confidence in the safe delivery of the vaccine, essentially there aren't really any legislative barriers as such. The person can be approved to administer vaccines if they meet a certain number of criteria.
How long? Are we talking days, weeks, months? Because all the DHBs are crying out for more vaccinators.
It's work that's actively underway. It doesn't take a lot to actually do the approval process. What's more important is that they have a training program that is appropriate for them. We're currently looking at what needs to be in that training program. We're really talking about a couple of months. The plan is really to get these workers able to vaccinate in time for our more widespread rollout of the vaccine. So, as I say, it's actively underway. It's got beyond consideration to actually work that's happening.
We'll come over here.
Have doctors been told what their role is going to be in the mass vaccination rollout?
So those conversations are ongoing. One of the key things was discussing with primary care the funding model for vaccinations. So that's now been agreed, if you like, and is being disseminated out to them. Primary care is going to play a very, very significant role in the rollout of the COVID-19 vaccine when we get to that point where we're delivering large numbers of vaccines on a daily basis. So a significant portion, when we get up to doing 50, 60, 70,000 a day potentially, a significant proportion of that is going to be in usual primary care settings. So people going to see their doctor. It might not be the doctor doing it, it might be the practice nurse. Primary care practices are used to administering vaccines. They do it all of the time, and they are going to be a very, very important part of the rollout.
Have you asked officials at any point for a system-wide audit of employers in the wider border workforce to ensure that they are meeting their legal obligations?
So I think I went through this a little bit last week, but there's a data matching exercise to go on there, so to assemble what data we do have, to make sure that we are at least getting that as aligned as possible. As I've indicated before, though, in terms of that baseline information about who needs to be tested, much of that will sit with the employer because of the rosters and all of those kinds of things. And we're talking hundreds of different employers, some of which are quite small businesses. So, a truck driving firm which only has one truck, for example.
Has an audit ever been done across all of those employers at the border workforce?
No.
Why not?
Just the practicalities and the potential expense involved in doing that. Look, we'll look at whether or not we can do that, but ultimately the legal requirement is clear. People need to follow the law here. We don't audit every New Zealander to determine whether or not they're following the law. People are expected to follow the law. Now, of course, if there are ways that we can monitor that more rigorously, then we'll look at those.
Sampling and MIQ that's been done.
Yeah.
Can that sampling be done across the wider border workforce?
No, one of the things that's allowing us to do that in MIQ is the who's on location system, which has been rolled out since February, which records who's been entering those facilities. Now, as I indicated, there's some evidence to suggest that not everyone's been signing in as they're required to do, but we can at least data match the data from that system with the register. That gets easier as all of those remaining employees who aren't on the register are entering their employees' details on the register. That'll give us more information than we've had.
Rolling that out across ports and airports or other places?
Well, if you think about the port, for example, there are thousands of people that go in and out of the port every day. Now, they do sign in and out, but data matching with the testing register isn't necessarily going to tell us much, because only a small number of those would actually need to be tested.
Janssen has quit the government's immunisation advisory panel, and he says largely this is because there isn't going to be an adjustment to the age at which Māori are prioritised for vaccines, so that it's sort of the general population is prioritised at 65 plus, but he thinks that Māori should be prioritised at 50 or 55 plus. Are you satisfied with the approach that you're taking there with that prioritization?
Well, first of all, can I acknowledge Dr. Janssen? He has been, a very useful contributor to the vaccination program so far, and I do respect his views. We have been very mindful of the fact that Māori are more likely to have an adverse effect from COVID-19 than other New Zealanders, and that is reflected in the way that we are rolling out the vaccine. So prioritising South Auckland, for example, where we know we have high concentrations of Māori and Pacific communities who are more at risk, prioritising in the rollout of the vaccine people who have those additional health-related conditions that mean that they should be earlier on in the vaccination process, and that includes a significant proportion of Māori and Pacific people within that grouping. So yes, we've been very mindful of that. There are different ways to target it, but we believe we are targeting it in the best way we can. Now, within that, there are going to be differences of opinion, and I certainly respect his opinion, though it doesn't reflect exactly how we're rolling out the vaccine.
The data on the Ministry of Health website indicates that for 7 weeks, from sort of mid-September through the end of October, New Zealand is going to vaccinate 534,000 people every week, so about 76,000 people a day on average for 50 days. Can we really do that?
I read your column about that this morning, actually, and look, it's ambitious. There's no doubt about it. It's going to really stretch our system. There will be some bumps in that. There'll be people waiting in line. There'll be issues of moving vaccine stock around to get it in the right place. Let's just be upfront about that. That's going to happen. But everybody, I think, wants to make this work. Everybody is absolutely focused on doing as much planning as we can now to make sure that it works. I know that primary care are chomping at the bit to get involved, and they're gearing up, ready to do it. But it is going to be big, and it's also going to rely on all New Zealanders playing their part too. So when people book in for a vaccine, it's imperative they show up to their appointment. One of the things that could really slow us down is if we find that there's a vaccination clinic that had 2,000 people booked in a day and only 1,000 people showed up. That's going to complicate the whole thing. It's going to slow down the rollout of the vaccine. So we really want people to come forward for the vaccine, to book in to get the vaccine, and to show up when they've booked in, because that will actually have a really significant bearing on our overall success when we get to those really big numbers on a daily basis.
The government has announced this morning its intention to create a public health agency, as well as consolidating the public health units into a public health service. As the Director of Public Health, what do you make of those changes? Do you think that they'll improve the ability to respond to public health issues?
Well, I've been working really hard on the COVID response, and that remains my priority for this year. And I look forward to the changes that were announced this morning, and I'm working with my colleagues to strengthen the public health system.
Globally, last week was the worst week yet in the COVID-19 pandemic, and that was driven by a staggering increase in cases in India. It's more than doubled since the freeze was announced. Are you expecting more cases to appear at the border going forward? And based off of what we had seen with those Indian arrivals over the past month, is there a need to increase the amount of quarantine space to deal with that?
So so I guess there's two things here. One is quarantine, and the other is managed isolation. So what proportion of our cases coming into New Zealand end up testing positive and therefore being moved from managed isolation to quarantine? Since we imposed the temporary restriction from India, we've seen that number come right back down again. So it's certainly very manageable at the moment. We will make announcements later this week around the future of that, and that will include the work that we've been doing looking at the risk profile globally. So not just India, and we've always been clear this is not just about India, this is about very high risk countries. So there's a lot of countries that are high risk, but there is a small group of them that are very high risk given what we're seeing. And India falls into that category. So we'll have more on that later this week, on Friday. I'll set out what we're going to do there. So we're just working our way through that. There's modelling work that's going on there. This isn't about singling out any particular country. It's about being very clear and transparent around what our framework is around, any travel restrictions, so that everybody knows what to expect there.
A worker at the airport has told us that ground crew interacting with passengers aren't being regularly tested, and some companies aren't keeping good records of this. Is that concerning to you?
I'd want to see some evidence of that. As I've indicated before, we do what we can to audit and to test those numbers. But if anyone does have any evidence of that, then please bring that forward, because ultimately those employers are not meeting their obligations. Other government agencies can be involved in that process, including WorkSafe, because if the employers are not ensuring their staff are being tested, then they're failing, A, to comply with the order that requires them to do that, but also they're failing to provide a safe working environment.
This is our only planned weekly update on vaccination, but you're bringing us data that's 5 days old. Why is that? Is that for design, or is that because some DHBs aren't getting the data to you fast enough?
No, look, as I said, that's just an issue around data, which we're going to iron out for next week, so that we don't have this issue, so that you're getting consistent data sets. At the moment, there's just an issue with the data sets don't align.
Are you able to tell us what company the cleaner worked for?
Yes, I do know the name of the company, and that's Menzies.
And also on COVID vaccinations, is there any update from MedSafe's approval process with the Johnson & Johnson?
No, my understanding is that they've asked for more information, and there's a couple of elements to this too that it's important to understand. So there's the MedSafe process, but then there's also a decision by Cabinet, which is around the decision to use. And those are two separate processes. They were very quick processes for the Pfizer vaccine. So once MedSafe had given their approval, the next one happened very quickly. But that, even once MedSafe has gone through the approval process for the Johnson & Johnson vaccine, the Janssen vaccine, Cabinet would then have to make a decision as to whether to use it and how to use it. And that's going to partly be determined by the fact that we're not expecting deliveries of that at the earliest until quite late in the year anyway.
Contact between the cleaner and the passengers on that flight been ruled out?
I don't think it's been ruled out, but we haven't seen any evidence of it yet. But again, that's what the investigation process looks to identify.
Wearing an N95 mask, is that
Yes, the cleaner was wearing full PPE, which we have checked that the protocols are being complied with, and that includes mask and a face shield.
Does that mean N95 mask?
Yes, it's an N95.
Have you decided
We'll come back to that. Oops, sorry.
the MIQ space is freed up by the trans-Tasman bubble, and if we'll be pulling any of the MIQ hotels off the network?
So there are quite a bit of work's been going on in that particular area. There was a decision to increase the overall proportion of rooms that don't get allocated on a regular basis to allow for greater contingency, including any disruption on the Trans-Tasman, should that be needed, should we need to isolate, a couple of plane loads worth of people, for example, from the Trans-Tasman, if we needed to do that at short notice. So we've allowed ourselves a greater buffer to do that. The changes to the way we are doing cohorting also has an implication for the overall utilisation rates for rooms. And I'll talk more about this on Friday because it's part of the changes we're making around very high risk and high risk arrivals. But that will have an overall effect on the efficiency. So by being stricter about the way we do cohorts, it will mean that a greater number of rooms won't be filled. So I'll set all of that out on Friday anyway.
That some of the MIQ hotels that would be taken off the network because they were appropriate for high-risk travellers or whatever. Have any been taken off? Or
Not yet. So we are in discussions with a variety of different sectors. There's a couple of things that at this point we're just working our way through. One is family reunification. You'll note that my colleague Chris Farfoy has made some changes there, which we expect to see flow through into an increase in demand for managed isolation vouchers. At the moment, there's a lot of vouchers available, so the system's there's not demand for full capacity at the moment. So we're looking at that. We're talking with the primary industries about RSE workers, recognising that there will be a number of RSE workers who have been here for a long time who want to leave, and they'll be looking at ensuring that they can replace those. So we're talking to them about that, and that may involve bringing in lower risk charter flights, for example. A number of those RSE workers come in on charter flights, and we could therefore utilise some of those facilities that in the long term we may not want to keep, but we may use them in the shorter term for things like RSE workers or even potentially lower risk cohorts of international students. So again, those are the sort of three areas that we're considering at the moment around that.
So what do you think about the fact that there are, if my maths is right, 500,000 doses of the vaccine just sitting there that could be getting into people's arms?
What we've tried to do with the framework that you'll see we set out last week is create a system where we don't have sort of waves of scaling up and scaling down, because that'll be quite disruptive to the overall ability to scale up in the middle of the year when we need to. So by progressively scaling up in a sustainable way, we get to the point by the end of June where we're doing sort of 18 to 20,000 vaccines a day. The following week, or the following weeks, we aim to get up to sort of the 30, 40,000 mark, and then it just progressively builds from there. The challenge is if you just flattened that curve out initially, the leap in the middle of the year is a much, much bigger leap. So this is just about making sure that the vaccine rollout is done sustainably, that we don't end up with a whole lot of people standing around in vaccination centres that don't have vaccines to be able to give to people. So it's been quite carefully planned. It does mean that we accumulate some in the beginning. We're now reaching the point where our daily numbers are starting to really get up there, where the growth in the available stock will stop, and over time, over the next sort of 10 weeks or so, it will go down as we scale up the delivery to the point where we get to about 95% of our available doses will be used by the end of June, and then we start getting the big deliveries in at that point.
So big buffer, like how big do you expect that buffer?
It won't get much bigger than what it is now, because we're getting to the point where we're starting to see bigger numbers on a daily basis. So over the rest of this month, we're expecting to see in that kind of 6, 7, 8, 9,000 on a peak day, potentially 10,000 on a daily basis. So it's starting to get there. Drops off a little bit over the weekends. That will, towards the end of the month, start to get up to over 10,000 a day on a more regular basis. And so when you're looking at 60 to 70,000 arriving on a weekly basis, it means that we'll be using them as they are, or broadly the equivalent number to what's arriving. So the stockpile won't grow, and then it will, as we get further into it, it will start to go down. Just the last couple of questions.
Do you have an update on whether or not there's been an increase in people paying their MIQ fees? And do you need any kind of extra tools to get people to pay? Because in the past, that number has been surprisingly low.
Yeah, so I'm looking at a couple of things around that. One is I think that the system takes too long to invoice people after they have left, and I think that needs to be sharpened up. Some of that's unavoidable. So, for example, people aren't automatically required. Some people aren't necessarily needed to pay when they leave MIQ. They'd only need to pay if they were to leave the country, again afterwards. And so there can be a bit of a lag there. But I think the invoicing process as a whole could be more timely, and I think that would help. So working with the team to make sure that we do have that information, that we get the invoices out quicker. And that includes assessing people for whether or not they should get an invoice when they're arriving at MIQ rather than when they're leaving. So that process should start on day 1 rather than start on day 14. So just working through that at the moment. The overall payment rates within the required time frame aren't too bad, but it is a 90-day payment terms period, which is quite a long payment terms period. And I think that getting the invoices out quicker would actually potentially improve things. Someone getting an invoice a month after they've left MIQ is less likely to view paying that with a degree of urgency of someone who's getting it the day they leave, for example.
Are there any insights that we can gain yet? I know it's very early about how the virus affects a vaccinated person is the cleaner's viral load low, and obviously we're interested in how transmissible someone who is vaccinated might be able to transmit the virus.
Yes, well, very good evidence beginning to emerge overseas about the impact of vaccination on not just preventing severe disease, but reducing any infection, and then even if you are infected, being able to reduce that transmissibility. So that's exactly what we want to see. Noting though that the vaccine doesn't work for everyone, we've consistently said it's a 95% effectiveness. That does mean there will be a very small number of people for whom the vaccine doesn't work. We don't know what in this situation whether that's been the case for this worker, but certainly from the evidence emerging from overseas, even if you are vaccinated, we would expect to see that your ability to pass that infection on to others is dramatically reduced.
All right, you can have the very last question.
Thank you very much. Do you know how many of the 17 close contact workers of this airport case are vaccinated?
I don't actually have that information. As border workers, they should all have been vaccinated, but I don't actually have that detail. We can get back to you with the specifics on it.
All right, thank you, everybody.